Good morning, everyone. Obviously, the talk today is on spinal fluid leaks and management of spinal fluid leaks. Let me see here. How do I move forward? Okay, so obviously not something anybody really wants to claim too much expertise in, but still very an important thing to do. Most of the sort of algorithms I use or the clinical sort of logic that I use comes from this guy, Paul McCormick, who is one of the very few neurosurgeons who has a primarily intradural spine practice. Obviously, that pathology is pretty rare, but he developed this scale early on in his career, and he's in New York City, and he just kind of developed the referral pattern, and most of what he does is intradural. So he's kind of unique in that way, but also unique in the sense that he's got, a couple of people with durotomies in the hospital at all times. And so obviously got very good at managing dural healing and CSF leaks, et cetera. That being said, there's a pretty big difference between a planned durotomy like you see here, which is closed sort of very, cleanly and linearly. This one was actually closed by our last fellow, Ryan, who's, I think, was smiling just like that picture immediately after closing it, as he always does. And he did a nice job. But, big difference between that and an unplanned durotomy where you start with a little bleb and you're wondering, oh, is that actually a leak? And you put your sucker by it and you get a big expulsion of CSF and you try to put a stitch and a patch and all of that stuff. But even though the fixture is different and the quality of the closure is different, the principles oftentimes are very similar in terms of trying to allow the dura time to heal and to get a good closure. So just a little bit of an introduction about the incidence. No real consensus in the literature about the rate, which is often the case with complications that can't be seen on x-rays and things like that. But regardless of the true consensus or the true incidence, it's a very common phenomena, one of the most complications of any kind of lumbar procedure. And incidence is said to range anywhere from 1%, which probably seems a little low, to 17%, which is obviously, if you're having a dural leak, 1 out of every 5 times you do a surgery, you're going to go out of business pretty fast. So the best data I could find is from this British study. And the cool thing about this is it's in a controlled healthcare system. So they've got pretty good data, as opposed to the United States where our data is sort of fragmented across hospital systems. And it was collected prospectively. So they were actually looking for CSF leaks, and it was 14 institutions across the UK. So as you might expect, quite a bit of variance between procedures. So 3.5 for just a discectomy, maybe a little bit surprising. They had a much higher incidence for lumbar stenosis, but that makes sense to some extent, I think, with the hypertrophy of the ligament and some calcification. And then not surprisingly, the incidence for revision is way higher, which I think is something that probably we've all experienced or observed. And then importantly, there's a pretty wide variation among spine surgeons. And I think that that's probably the case here in the United States as well. And so, how do you sort of tell patients what to expect? Oftentimes they want to know, well, what's the risk or what's the percentage of a risk? And I don't necessarily want to tell somebody that's got lumbar stenosis that there's an 0.5% chance that they're going to have a spinal fluid leak. So I think the one way that you can kind of be genuine and sincere is you just kind of collect your own data. And for, Dan and Rob or any of the other fellows that are listening, I think it's a good idea to just come up with a pretty crude way to collect your own data. And this is mine. It's just an Excel spreadsheet, and it's good for keeping the coding and for what implants I used, and also for complications, and then as you can see in this spreadsheet, my incidence before and after March 22nd or whatever increased dramatically because I had 2 in a row. And then, you have to kind of change your assessment and say, okay, maybe it is a few percentage points higher, but at least then you can be sincere and have your own sort of sense of what your own rate is. And it'll be good for boards collection. And having a sense of your own data is probably good, because if you don't collect it, someone else probably will. This is a study that looked at trying to predict the risk of CSF leaks, but it did it through this natural language process identification algorithm. So they created some kind of AI that would look through all of the op notes and identify CSF leaks. It would look for things like Duragen or Duraseal in the op report. And so, yeah, so if there's a way to do it that simply, then somebody's probably collecting that data. So you're going to want to know what your numbers are. They looked at over 1,000 cases, and they found pretty similar to the British study, the incidental neurotomy occurred about 8% of the time, which again seems high, but maybe that's the real number. So what were the risk factors that kind of came out of their regression in this predictive scale? Not surprising, surgical duration. So, bigger, longer surgery, more opportunity for a CSF leak, no surprise there. Older age, this is pretty obvious, I think, probably to most neurosurgery folks, but for the orthopedic folks. So when you're doing like any kind of brain operation in an older person and you're trying to close the dura, it's just awful. So like the tensile strength of dura actually falls off pretty precipitously. So it's not as obvious in spine surgery, but in brain surgery, you really see it. The older folks' dura is it can be like tissue paper. And so obviously that's going to increase the risk. Again, revision versus index, obvious, the scar. I think that's probably, in my practice, at least the number one risk factor is if it's a revision. And then if the case starts after 4 p.m., which again is not a huge surprise, an unfortunate one, but not a huge surprise if you're kind of tired or rushing. Not risk factors, importantly, it has nothing to do with whether you're a neurosurgeon or an orthopedic surgeon. It was not associated with having a resident or fellow involved. And it was not associated with whether that resident was a PGY1 or a fellow. So, at least at Hopkins and Harvard, where this data was collected, it looks like, the appropriate level of supervision was there. If you were a PGY1, you had more supervision. And so that sort of didn't increase the risk of spinal fluid leakage. Experience as a surgeon, so years out from training, didn't have an impact, which probably makes sense to me. I mean, maybe the more experience you get, you're a little bit more expeditious. And then BMI did not have an impact. And there were previous studies that showed that BMI was associated with it. But I mean, I guess if you're doing MIS cases, the length of your tube is longer, and the longer the tube, the less your dexterity. So I'm sure if you had a large enough sample, there would be some association with BMI, but they didn't find it in 1,000 cases. So, a durotomy is technically a minor complication. It's something that almost all of us will mention when we're going through the risks of surgery. But it is the second most frequent cause of medical malpractice, at least in this review. So not something that everybody necessarily considers minor. And obviously there can be significant consequences. The classic postoperative positional headache, the most common of those, but it can also increase the risk of meningitis. Some question as to whether or not it can increase the risk of a new neurodeficit, either through the difficulty of primary repair, or if there could be some traction on a nerve or something like that. I think that is something that's debatable. I don't know if that's, a really statistically significant association. And then obviously, if you don't get a good primary closure, a pseudomeningocele will ultimately form, or they'll just continue to have leakage, neither of which is necessarily a good thing. So there is some data that demonstrates that it actually affects quality of life scores, which isn't a surprise, but it's statistically significant. Similarly, not a surprise that it's going to affect patient dissatisfaction, but it's not a negligible amount. It can actually increase it up to 50%. I don't know if that's what caused the Hulk to bring the Laser Spine Institute down. I just showed that as a case of dissatisfaction because I think it's funny that Hulk Hogan brought the Laser Spine Institute down. And then obviously cost. There's a huge impact in terms of cost. So it increases the hospital length of stay, particularly for an outpatient discectomy or an outpatient LAMI that turns into, oftentimes a 2-night stay in the hospital if everything goes well with the repair. Postoperative antibiotics, that's probably relatively small. And then revision surgery, which is obviously a huge cost. So there's some data on that as well. There's a study that looked at the Medicare database, and it said that expenditures are about $4,000 higher per patient, which was almost a 2/3 increase in the cost. So obviously pretty dramatic there. And then Pearl Diver is a database that doesn't look at government payers, but rather sort of a multi-payer insured data set. And the 90-day cost, so the 3-month out cost, was $10,000 higher, which is 120% of the average cost without a durotomy. So obviously a very significant increase there. And it's primarily due to twofold higher rates of readmission and prolonged hospitalization. Okay, so it's going to happen regardless of your specialty, if you're ortho, if you're neuro, regardless if it's your first year out of training or if you're, super experienced. It's going to happen if you're in private practice and you never let a resident or a fellow touch your patient. Technically, yes, it's a minor complication, but it impacts quality of life, certainly impacts satisfaction, has implications in the medical legal realm, and has a really dramatic impact on cost of care. So management is critical because it's going to happen. So I think, importantly, especially for the fellows, this is kind of written for you guys, but don't panic. You're not a loser who was husky growing up and whose mother always loved their sister more than you. It happens to everyone. And you can't pretend it didn't happen, like this tattoo that turned into a big black square. You kind of just have to deal with it. So my steps, as soon as I see that gush of clear fluid, and I've only had one CSF leak that I didn't immediately recognize, one unintended iatrogenic durotomy. Every other one I've had, I've immediately knew, as is almost always the case. So the sort of steps that I go through, again, this is sort of reflective of Paul McCormick. You cover it temporarily with a patty or whatever, just to kind of collect yourself, take a deep breath. Tell yourself, I oftentimes will say it out loud as the fellows will learn. You can just kind of tell yourself, this is going to be the best chance I have to fix this problem for this person. Don't dwell on the fact that you created the problem and, shoot, now they're going to be here for 2 days and nobody's going to like me anymore. Just forget about the guilt. There'll be plenty of time for that. Trust me. And just say to yourself, this is the opportunity to fix this problem and focus in on that. And I think that kind of helps you think about it differently. Couple of pearls, 3 main concepts. No substitute for a good primary closure. Number 2, no substitute for good primary closure. Number 3, no substitute for good primary closure. And I think that is just like the most critical concept. And so with that in mind, you have to kind of optimize everything for that primary, prepare for that closure. And so sometimes that means expanding the incision. More often it means taking some additional bone down, particularly if it's in the context of like a lammy. Usually the durotomy will occur when you're trying to get a curette or a kerrison underneath the bone, or when you're out sort of, lateral to the dura. It might happen close to the nerve root sleeve. It's oftentimes an awkward trajectory with your needle driver, or you don't have a lot of room to turn the needle. You need to see it. You need to have enough space to turn a needle. So take down a little more bone, see the defect, prepare yourself. I almost always use the microscope. I almost always use the micro instruments for the same reason, because it's hard to turn the needle without those micro instruments like a Castro. And then if necessary, convert MIS to open. So I have these special instruments. They're made by Scanlan, where you can actually throw a needle through an MIS tube, like even an 18 millimeter MIS tube. And in like the hubris of being a fellow, I was like, oh, I'll make sure I get these instruments so that I can do like intradural tumors through MIS tubes. I've not done any intradural tumors through MIS tubes. I think it's better to just do an open lammy, but I do use them if I have a durotomy through an MIS tube. If you can't get a good closure though, I think the threshold, and I've had to do this once or twice too, just taking the tube out, doing a midline takedown and seeing the defect, repairing the defect, that threshold should be low. It's much better to tell someone that you had to convert to a regular, paraspinal exposure and you fix the problem than leaving it there. There is some school of thought where like if you have an MIS opening, that like the CSF leak will kind of solve itself or heal itself. I don't really subscribe to that. There's still enough potential space for the fluid to continue to collect. And then I think it's important to determine which instruments or materials work best in your hands. So in terms of suture, most folks I think use either Gore-Tex and or Prolene / Neurolon, either 4.0, 5.0, or 6.0. I always just kind of grew up using 5.0s. The benefit of Gore-Tex and Neurolon is that they're not absorbable. And then one important takeaway is that the caliber of the stitch should not be larger than the caliber of the caliber of the needle should not be larger than the caliber of the actual stitch. If it is, then obviously the hole in the dura is going to be bigger than the stitch that fills it, and that'll allow for continued leakage. So most of the 4.5.0 needles are not going to have that problem. And then finally, if you have a needle with a pretty acute turning radius, that obviously makes it easier to turn in small corridors. So I actually, learning from McCormick, I actually use a 5.0 silk. It is not as strong as Gore-Tex or Neurolon, but it handles better. So if you throw like one knot with a silk stitch, it'll hold it. And that's kind of important when you're trying to close a durotomy, and it really handles well. And so I think more important than the strength of the stitch, to loading or anything like that, is that you just get like an actual proper closure and you get the two edges of the dura to approximate. So I guess the lesson would be for the fellows, just kind of play around with it, figure out what works for you, go with that. I also don't like that the Gore-Tex is the exact same color as the dura. That kind of throws me off. So sealants, obviously, it's something that most of us use. The one that we have at Scripps is Duraseal. So there was a review that looked at this very recently, this year. It was published in February. So the most common technique is a combination of trying to close it primarily, using a patch or a graft like Duragen, and then using a sealant like Duraseal. However, the lowest rate they found was just using a primary closure with the graft. The sealant did not increase the success of the repair. So, a study like this, it's kind of hard, I think, to really tease these things out. There's no good data that suggests that the use of the sealant significantly improves the situation, but I think most of us use it. And then there's this question of how do you use it? Do you put the patch over the repair and then you put the sealant on? Do you put the sealant on and then you put the patch over the sealant? And obviously, these are not things that we've got good data for. The manufacturer suggests that you just kind of put it right on the defect by itself, and they give you these diagrams. But at least in my hands, and this is, again, not evidence-based, I like to basically put a little bit of sealant or Duraseal on the repair site, and then I'll put a patch over it, Duragen, and then I'll put sealant over the patch, kind of like a sandwich. And whether one is better than the other, I can't say for sure. I've heard some folks say that it's good to have the sealant in so it closes all the little crevices. I've had other folks say that by getting the sealant into those crevices, it prevents the Duragen from properly healing. I don't know that it's been worked out yet, but I think the far more important point is just that you get a good primary repair. And then whether you do the sandwich technique or whatever is probably fairly irrelevant, but I do think it helps. You may have heard of these clips as well. One or two folks have come by my office and showed me, clips for dural repair. It makes a lot of sense, and especially when you're in a small corridor, is it easier to place a clip? And technically, they are stronger, which is what this study shows. But it's also technically pretty difficult unless the durotomy is in the dorsal, exposed thecal sac. Getting a clip in at an angle is just really hard. So even though, yes, it's technically stronger, I think it's probably technically a little bit more difficult, which is why they've not gotten too much traction. I've never trained with anyone or known anyone that uses primarily clips. So, okay. So if, say, I'm doing a discectomy or a LAMI or something like that, or a spinal tumor, whatever, and I get a durotomy, either planned or unplanned, I like to leave a Hemovac to gravity, which I just mean, you don't compress the accordion. One of the nice things about this is that it gives you some information about the CSF leak. So if you have a Hemovac to gravity and it's filling up with, bright red blood, maybe not on day one, but on day two, then you've probably got a fair amount of reason to suspect that it's not leaking the spinal fluid. But if it's leaking clear pink stuff, then you probably do still have some leakage of fluid. And so in that scenario, say it's post-operative day one and there's still some leakage of fluid and most of the blood is cleared from the Hemovac on gravity, then you can clamp it, and that will allow the potential space to sort of pressurize, fill up with fluid, and it'll prevent the flow of fluid, which should allow the dura to heal. But it also prevents against the one-way valve effect. And so if you think about the durotomy in the thecal sac, fluid can get out of the thecal sac, but it can't get back in. And so it can create a pressurized pocket. And that's what happens when you may see somebody that had like a CSF leak that was not recognized or recognized and not properly repaired. And like 2 days later, they get really severe claudication or radicular pain. The fluid is being expelled from the thecal sac into the potential space. It happens a lot in MIS cases because that potential space is small. And if the fascia is closed, that space can just fill up with CSF and pressurize. And you might think, well, why would CSF flow into that space if the pressure there becomes greater than the pressure inside the thecal sac? But the reality is, if you're standing upright or if you have Valsalva, you can have a transient increase in the intrathecal pressure. And that can expel some fluid, which then can kind of pressurize and create this pressure effect of a one-way valve. So if you have a Hemovac in place, you can always clamp it, see if that occurs. And if it does, you've got a way to drain that fluid and then maybe go back and repair the defect without folks having to have any sort of radicular or neurologic consequences. So flat protocol, I thought one thing that was kind of probably worthwhile touching upon, obviously the concept is that you don't want the pressure of the water column to collect at the site of the dural healing or the dural defect that you've repaired. So this diagram, which is kind of crude, but it just sort of shows that if you've got a tube that's not completely filled with water, obviously the water's going to collect to the bottom. And so if you have somebody on their side, then that fluid is going to equilibrate along the length of the dural tube, and the pressure of the water column will not sort of be as intense. Now, I've heard some folks say that, when you have like a cervical durotomy, that you should keep the patient sitting upright. We never did that where I trained, and I thought a little bit about it, but I've never heard of any of my colleagues in neurosurgery at least doing it that way. And I think the reason is that although you've got less CSF in the thecal sac than you normally do, the water column is still going to be above any cervical defect. I mean, you're down some CSF, and you may have some contraction in the size of the ventricles. That's what causes the headache, but it's still a water column that far exceeds the cervical spine. If it didn't, you'd have a massive subdural. So even in cervical cases, I still think that the patient should be lying flat, and certainly that's the classical teaching, at least I think amongst most neurosurgery programs. And so I have everybody flat. If it's a cervical tumor, they're flat. If it's a cervical iatrogenic durotomy, they're flat. And usually, depending on the leak, it's for 48 to 72 hours. So when do you place the lumbar drain? There's kind of a classic teaching, which is if you have to be thinking about it or asking yourself, if I need to place a lumbar drain, that means you have to place a lumbar drain. I don't know if that's necessarily true. And oftentimes, there's been a leak and I thought about it and didn't place it, and it was fine. But I think the sort of mantra I use is if I'm closing the wound, and I could still see there's some fluid leakage, or I still was able to appreciate some leakage of fluid despite my repair, or if there's any other source of doubt, if it's a super old person that had really poor dura or any other concern, then I think it's probably a good idea. And it's really not that hard to do, especially if you incorporate fluoro. So there was this guy at Columbia where I did my residency who did a ton of shunting. And so a trial for shunting is to place a lumbar drain. It's also a hurdle to put in front of people that may need shunts, so you have to do less of them. But either way, I've done a ton of spinal drains for that reason. And it's, once you get comfortable with it, it's just a super straightforward procedure. It's really not much harder than a lumbar drain, or excuse me, than a lumbar puncture. And you don't need anesthesia. It can be done just with constant sedation. It can be done in the OR or at the bedside. If you're at the bedside, you just need to be really careful about your sterility. In the OR, I used to do it in the lateral to cube. I've moved towards doing it prone on a Wilson just because I think the fluoro makes it so easy. You can essentially guarantee that you're going to do it with one poke. So when you have them on the Wilson, you just get an AP and you should see something like this. You can go in 4-5. I often go in 3-4. And I usually start at the 4-5 interspace. And then I just try to get down to the level of the thecal sac by the time I advance the needle cranially to L3-4, and you just kind of shoot for midline, and it's pretty reliable. So assuming that you are in the CSF space and you get that flush of fluid, the only thing that's different than an LP, obviously, is that you've got to advance this spinal drain. And if you look at this diagram on the right, C is the stylet and D is the actual spinal drain, which is a very thin, low caliber drain. And so you essentially open up the spinal drain, and at D, you advance the stylet, which is in C, all the way through the length of the spinal drain. You want to have all of that ready. And then as soon as you get your sort of rush of spinal fluid, I just start advancing the drain. I usually shoot for about 20 centimeters at the skin. You don't want to insert the entire drain. You can put it in somebody's posterior fossa. I saw that once, which is kind of a big deal. But 20 centimeters should be safe and should prevent it from pulling out, even in a pretty robust patient. Once the drain is in, then you can pull the needle back over the drain and pull the stylet out, and then you secure it. It's not difficult. Dan, Rob, you guys should definitely do a few. I know Dan has already done a few, and then I think you'll feel pretty comfortable doing it. Importantly, once you start pulling the needle back, you can't advance the needle again over the drain, or it'll shear it off, which I'll go over with you today, Rob. Obviously, you can have IR do it at most places, or Dan or Rob, you could ask one of your neuro partners to do it. But I think it's a nice thing to just be able to do yourself, if possible. So what's the protocol? So if I place a lumbar drain, that's essentially, guaranteed somebody's going to be in the hospital for 2 to 3 days. Otherwise, there would be no point to placing it. I keep them flat, obviously, for to minimize the postural headache that you should have if you're having a lumbar drain placed, but also just to take pressure off the dural closure. If you're going to be flat for 2 to 3 days, I think it's good to allow people to sit up just a little bit so they can use the commode or whatever. But also for meals, just so they don't aspirate. But for the most part, I like to have them flat. And then the rate is variable. There's not a whole lot in the literature. I always did 12 every 2 hours. Some people will say as much as 20. Oftentimes it'll be dictated by what the patient can tolerate. Even at 12 every 2 hours, which is probably on the lower end of what's reported, patients will often get a pretty bad headache. And when that happens, I just will skip a drainage period and just say, okay, this next 2 hours, don't drain anything, and then we'll start again. So you can kind of titrate it to what they can tolerate. Another issue is continuous versus intermittent. So what that means is, do you just leave the spinal drain open contiguously, like we do with like external ventricular drains, or do you open it periodically? So the problem previously was that if you left it open continuously and the nurse wasn't paying very close attention, then too much fluid could drain, and that can create pretty dramatic complications, the most common being a subdural hematoma. And so a lot of hospitals had policies where they wouldn't let it be drained continuously, or if it were being drained continuously, it had to be in the ICU, or a nurse could be watching it at all times. Integra made this sort of collection Dural shown on the right, which has this, I don't know if you can see it, but it has this little limited chamber. So you can't collect more than 20 cc's of CSF, or it won't advance anymore, it won't pull any more fluid. So that kind of protects against getting a subdural, and you can have it just wide open. the problem with that is it's pretty hard on the nurses, I think, to like be raising the bed and lowering the bed to try to get like 20 cc's or 12 cc's or whatever every 2 hours. It's creates some frustration. And so I usually just have folks go to the floor and I just have the nurses drain off 12 cc's every 2 hours. And that's a little bit easier on them. And there's not so much hand wringing and sort of anxiety around the spinal drain, which is obviously helpful for everyone. So that is kind of my paradigm. It's, some of it's literature based, some of it is just sort of empiric experience and what I learned from my mentors. And I don't want to have too much expertise in it, but like everybody else, I've had my trials and tribulations, and this sort of strategies work pretty well for me. Dan, Rob.
Really nicely done, Hani.
Oh,
hey, question for you. What's been the approach for you guys in DVT prophylaxis with these challenging situations where patients are bedridden for 72 hours on their back or side, and historically we haven't wanted to use anticoagulants, but it's a catch-22 kind of scenario.
Totally. I've never seen so here's what I would say. I've never seen an epidural hematoma created by a drain being removed. I have seen one from a drain being placed, but I think, like the way we used to place these drains when we were residents, it was like the last thing that you would do at the end of the night. And so you'd be like there at 10 p.m. and it'd be some normal pressure hydrocephalus patient, and you'd be like sticking them 40 times because you didn't know what they were doing or what you were doing. And so in that context, it's pretty clear that you could create an epidural. But if you're in the OR and you're doing it with fluoro and it's one pass of the needle, I think the risk of creating an epidural hematoma versus the risk of them developing a DVT over the course of 3 days, you kind of have to take that into account. And so if it's an older person or a person with a history of DVTs, I do start them on DVT prophylaxis the next day. So, I try to make sure that they don't have any blood thinners obviously on board. If it's like a normal pressure hydrocephalus patient, I want to make sure they're not on aspirin or anything like that. But I'll start them the next day. And,
Okay.
I've not gotten burnt yet. And most of them have Foley's in as well, obviously, especially if they're female. If they're male, they can just kind of roll to the side and use a little collection of Dural. But
cool. I'll just reiterate what Hani said about handling. I think the silk is way easier to handle.
It is, right? Yeah.
The rationale, and you didn't mention this, but one of the rationale points for the Gore-Tex, I think it was popularized by Vaccaro, was that the Gore-Tex expands to larger than the needle bore. So it seals up the holes that you're making with the needle a little more adeptly. I don't know if that's true or not, but that's one of the reasons I think people move to Gore-Tex, but it's a way bigger pain in the butt to tie because it's slick in relative terms. So grabbing it, you don't have the right instruments for it. It's definitely a greater point of frustration. So when you're doing it as a fellow and you're just getting your teeth cut, doing your first durotomy repairs, I would actually defer a little more towards handling characteristics so you build your confidence and not feel like you're scrambling and getting hamstrung left and right trying to handle Gore-Tex or something that's not quite as fast at all.
Right. And I think the likelihood of there being a recalcitrant CSF leak because the size of the needle holes or the stitch doesn't expand versus you not actually getting good apposition of the dural leafs. I think getting good apposition of the dural leafs is way more important. And, there's probably a few cases where having an expandable suture would make the difference, but I think that's a pretty small percentage.
Right. Last thing is that Kevin Foley designed some new dural repair kit or instrument, especially for MIS. I have not used it, but it looks pretty slick. So I think we have that available. Have you seen that?
Folks had yeah. So I've seen it. I've not had the opportunity to use it since I just saw it, I don't know, a month ago or something like that. But I'm sure my number will be called sooner than later. And when it is, I'm interested to try it. My only concern about that, or my only reservation, is the whole system only deploys one stitch. So I don't know, maybe that would be like the first stitch, like the keystone stitch, and then you could put another stitch if you needed it or something like that.
Cool. Well, thanks, Hani.
All right, cool, guys. Have a great day.